This is Complex Disease Management Module 6, and this will cover incentive spirometry through voice disorders. Incentive spirometry can be used for assessment as well as treatment. Use of incentive spirometry is indicated when a patient has less than normal vital capacity. Recall that vital capacity is the amount of air that's exhaled after a maximum inhalation. So I wanted to review respiratory volumes and capacities just a little bit before we get started. Got this diagram. Remember that. Whoops! I should have gotten a different paper. Oh well, shoot. I have to remember that moving to the right is opposite of what I think it's going to do. Okay, tidal volume is the amount of air inhaled or exhaled at rest. Residual volume is the amount of air that's remaining in the lung after a maximum exhalation. So remember, residual volume is going to rise in people with obstructive lung diseases like emphysema because they have trouble getting the stale air out. I know I'm not using a medical term called saying stale air, but that's the problem they have. They have rising residual volume. Total lung capacity is the amount of amount of air in the lung after a maximum inhalation. That's the total lung capacity. So those are just the four volumes that the respiratory therapist I went and talked to about before this presentation. She thought those were the four main volumes. So vital capacity is the amount of air that is exhaled after a maximum inhalation. That's the amount that incentive spirometry deals with. Tidal volume is the amount of air inhaled and exhaled in quiet breathing. Residual volume is the amount of air that's left in the lung after a maximum exhalation, and total lung capacity is the amount of air that's in the lung after a maximum inhalation. Okay. Before we talk about the goals of incentive spirometry, let's review two terms. Alveolar ventilation is the air that moves into the lungs, so by breathing. And then atelectasis is collapse of lung tissue that affects all or part of a lung. This condition prevents normal oxygen absorption into healthy tissues, and atelectasis can result from blockage of the airways that affects the alveoli. Alveoli are very thin, so they're like, again, I talk about the broccoli turned upside down. So alveoli are the little flowerets of the broccoli. Alveoli are very thin-walled tissues and contain a rich blood supply because that's where the oxygen is picked up from the lung into the alveoli. Yeah, is where the oxygen is picked up into the blood. The purpose of the alveoli is the exchange of oxygen and carbon dioxide. When the airways are blocked by a mucus plug, a foreign object, like when a child swallows a nickel or a piece of cut up hot dog or a carrot, like my son did several times as a baby, or a tumor, blocked by a tumor, the alveoli are unable to fill with air, and collapse of that part of lung tissue can occur. So now we can talk about the goals of incentive spirometry, having reviewed the terms alveolar ventilation and atelectasis. So the goals of incentive spirometry are, and these can go right into your documentation, are to improve alveolar ventilation, which in easy terms, get more air into the lungs. The goal of incentive spirometry is to get more air into the lungs, and to promote cough, to prevent or decrease atelectasis, to decrease retained secretions, and to increase respiratory muscle strength. What does spirometry do for people with COPD, since we have so many of those people? And there has been some, I have been doing some of the reading, should people with COPD do incentive spirometry? I found a Turkish study that found, I had to dig deep. No, I just took the first one that I found, and that made some sense. A study found that the use of incentive spirometry improves the arterial blood gases and the quality of life in patients with COPD exacerbations, although it doesn't change pulmonary function, which is what I would expect. We're not going to change the physiology of COPD. The damage is done, but it does improve their arterial blood gases, and it improves the quality of life measures. So they feel like they have more energy. They feel like they can, get their things done. They're satisfied with their life. They don't get anxious. They don't feel depressed. That kind of thing. So it is worthwhile to do incentive spirometry with COPD patients, and with the way reimbursement is going, there does need to be research support for the interventions that we use. Dyspnea. I'm going through some of the. If you're following along with the manual, I do skip around because I made an executive decision that the order they were in didn't make sense, so I switched around some. But I'm on the dyspnea page now. Dyspnea on exertion, it's self-explanatory. When they exert themselves, they get short of breath. Step beyond that is when they're dyspneic at rest. So certainly make a note of that when people are dyspneic at rest, in addition to dyspneic on exertion. Orthopnea or orthopnea, either pronunciation is correct. It is shortness of breath when lying down. One cause of that is due to the increased distribution of blood to the lungs when lying down. It moves from the feet up to the chest. It's often a symptom of left ventricle failure and or pulmonary edema. And pulmonary edema is the buildup of fluid in the alveoli. Remember, this is supposed to be, alveoli are supposed to be the agents of, or the area of gas exchange, carbon dioxide and oxygen. And when you have pulmonary edema, there's fluid there, so oxygen and carbon dioxide exchange can't take place. Orthopnea can also happen in people with asthma and chronic bronchitis, in people with sleep apnea or panic disorder. Platypnea. You need to correct the spelling in your participant manual. It should be spelled Platypnea. And it's dyspnea that's relieved by lying down. It worsens when sitting up. It's uncommon and results from an anatomical defect that's usually corrected by surgery at birth. Paroxysmal or nocturnal dyspnea. It's attacks of severe shortness of breath and coughing, sometimes wheezing that wakes the person up. And it's usually very frightening to the patient. And it's good for us to know about this, because I can totally see that we spend so much time with the patient that they would tell us about it. It may be caused in part by depression of the respiratory center during sleep, especially in patients with reduced pulmonary compliance, and a message gets sent to the sleep center and tells them to wake up. Also, in the heart horizontal position, there's a redistribution of blood volume from the lower extremities to the lungs, like we just talked about, orthopnea or orthopnea. In normal people, it has very little effect, but in patients in whom the additional volume can't be pumped out by the left ventricle because of disease, cardiomegaly or cardiomegaly or decreased stroke volume, heart attack, so there's not the strength of that left ventricle. Ooh, the sun went down or something. It got dark. Not the sun went down, a cloud went by. There's significant reduction in vital capacity and pulmonary compliance with resultant shortness of breath. It is really dark. In patients with congestive heart failure, the pulmonary circulation may already be overloaded because of the failing left ventricle, and it's suddenly unable to match the output of the more normally functioning right ventricle, and that can cause pulmonary congestion. Pulmonary congestion decreases when the person sits upright, and because then that fluid can go down into the lower half of the body, and the symptoms improve. Now we're going to cover dyspnea scales. Or I'm so sorry that I've got half of a face. Let's see if that makes it. Yeah, that's a little better. Maybe you like me having half of a face. Dyspnea scales. The Borg's rate of perceived exertion level. It was developed by, I'm going to give you a little history on who developed it. It was developed by Gunnar Borg, so it is really named after a person, in the early 1980s. The perceived exertion scale is a subjective method based on how hard you feel like your body's working during exercise. It's based on a person's experiences during exercise, and it gives a correlation between perceived exertion and actual heart rate. The RPE is a good estimate of actual heart rate during exercise. When exercising, the person rates how hard they feel they're working. It's the person's perception, and this feeling should reflect how strenuous the exercise feels to them. It's helpful in self-monitoring throughout the exercise training session. It was first introduced as a scale 6 to 20. A high correlation exists between the person's perceived exertion rating times 10 and the actual heart rate during physical exercise. So a person's exertion rating may provide a fairly good estimate of the actual heart rate during the activity. For example, if the person's rating of perceived exertion is 12, then 12 times 10 is 120. The heart rate should be approximately 120 beats per minute. Note that this calculation is only an approximation of heart rate, and the actual heart rate can vary quite a bit depending on age and physical condition. But that is the science behind it, and the reason that the scale starts at 60, at 6 and not 1. The Borg rating of perceived exertion is also the preferred method to assess intensity among people who take medications that affect heart rate or pulse, like beta blockers, or Cardiolol. Beta blockers. I pulled blank. There's another one. I'm sorry. Then there's a modified Borg scale that's 0 to 10. You can use either, but make sure that you document whether you're using the Borg or the modified Borg, because if you say a 6, it can mean quite different things on a scale of 0 to 10 or 6 to 20. So make sure you note whether you're using the Borg or the modified Borg. Okay, so like for example, on the 6 to 20 scale, a 6 is no exertion at all, but on the modified Borg, a 6 is very heavy. The talk test is also a good indicator of measuring exercise intensity. You should be able to carry on a conversation and still breathe comfortably, but not able to sing. I know we're not going to have, most of us aren't going to have people sing, but if you can sing and exercise, the intensity may be too easy, and we need to take it up a notch. But you should be able to talk during exercise. The next part is to talk about Rales and Ronchi, and I'm going to try to pull up this site, but we'll see. So crackles, when you're listening to breath sounds with a stethoscope, we can talk about crackles. It's the same thing as Rales. Crackles, they're trying to stop the use of that term. Fine crackles are brief, discontinuous, and that's the key word, discontinuous popping sounds. When fluid or mucus collects in the outer portions of the lungs, so when we're talking about the outer portions of the lungs, more towards your sides, not the central bronchus, midline portions of the lungs, the bigger tubes of the lungs. So when fluid or mucus collects in the outer portions of the lungs, the alveoli collapse and the walls of the alveoli stick together. Then when the patient tries to inhale, the alveolar walls are forced open and the crackling or the popping sound is created. Fine crackles are also similar to the sound of wood crackling in a fireplace, or hook and loop fasteners of Velcro, or cellophane being crumpled. Another description I've heard is like rubbing hair together. They can be heard on inspiration. Crackles and rails can, I say not and rails, crackles / rails can be heard on inspiration and expiration. Early inspiratory and expiratory crackles are the hallmark of bronchitis. Late inspiratory crackles or rails can mean pneumonia, congestive heart failure, or atelectasis. Compared to fine rails, so fine, they're real, real fine sound is what I mean. Coarse rails are louder, lower in pitch, and last longer. They've also been described as a bubbling sound, like a milkshake being sucked up through a straw. Now I'm going to try to pull up this site. I'm going to try. Okay. Okay. Let me get rid of that one. Okay. Now we're going to talk about rhonchi and or wheezes. Those are long continuous sounds, whereas rails are discontinuous sounds. There's a break between the sounds. Rhonchi or wheezes are continuous sounds. Sounds defined as rhonchi are heard in the chest wall where bronchi occur. So this is more closer. This is closer to midline, not over any alveoli. These are caused by air passing through mucus plugs in the upper divisions of the tracheobronchial tree. It can be a high-pitched whining sound, type of sound like that of a humpback whale, and that's the type of wheezing that or sound that you associate with wheezing. Or it can be a low, snoring, gurgling, rattling type of sound that we often call rhonchi. Usually rhonchi are worse in supine because the airways get smaller in supine because of gravity, and the narrowing gets worse. So if you're trying to hear rhonchi, it might be easier to hear rhonchi in the supine position. Diffuse rhonchi suggests asthma or COPD. Localized rhonchi suggests a localized obstruction like a mucus plug, tumor, or TB. Localized rhonchi should clear after coughing. So when, like smokers, when they get up in the morning and do all that hacking and coughing and clearing their throat and all that awful noises, they're clearing mucus plugs, and then their breath sounds are more clear. So when somebody has the strength, has good respiratory muscle strength and good breath control, they can clear their rhonchi. It's the people who don't have good respiratory strength that we end up seeing for the chest vest and for respiratory muscle and core muscle strengthening. Inspiratory rhonchi in general implies a large airway obstruction. Asthmatics will have inspiratory rhonchi, while it's uncommon in COPD. So I'm going to see if I can find rhonchi. Okay. Here we go. So this is the sonorous rhonchi, a sibilant sibilant rhonchi is the wheeze sound. You can call it sibilant rhonchi or wheeze, and the low rhonchi is the one that sounds like a snore. It takes a while for this to load. Oh wow, that is really low. There's no way you'll hear that. There's no way. There's no way. Well, that was useless. I tell you what, it sounds like a bee. It sounds like a bee. That was pretty bad. I'm sorry. The other one was so good I didn't listen to that one ahead of time, so I'm not a good Girl Scout. Let's see if this I've listened to these before. Here's a sibilant rhonchi. Hopefully this one won't take as long. Yeah, and it's as bad. It's just as bad. But we've all heard wheezing. And now the thing is, when you're listening to breath sounds, and sometimes people have said, well, I can't hear breath sounds. I can't hear anything. They have to take a deep enough breath for air to move past that mucus. So you need to tell them, take a deep breath. I need you to take a deep breath. Deeper. I need you to take a deep breath. So if you're just listening and if you put the stethoscope up to their chest and they're just barely moving air in and out of their chest, you're not going to hear anything. So you need to stir them up. May need to have them do some upper extremity movements, transfer them in and out of the chair to get them to taking some deep breaths, because you're not going to hear anything. And sometimes when I see in the nursing documentation lungs CTA, I think that's why they are CTA, because they're not moving their chest wall at all. If we took, like we talked about in Module 5, you take a measurement around their chest at the xiphoid level, I bet you there's chest expansion of 0 or 1 millimeter. If there's not air moving through the airways, we're not going to hear anything. You don't hear, and I don't mean to be disrespectful, but if we listened through a stethoscope to someone who's expired, we're not going to hear any breath sounds. So if the chest wall is not moving, we're not going to hear rales and rhonchi. We have to tell them to take a deep breath so that we get air moving past that mucus, so that we can hear if there's mucus in the airway that's blocking the passage of air. Okay, get off that soapbox. Okay. Another sound that we can listen for, which I have not, so I need to practice this, is lung resonance. And lung resonance is defined as a prolongation or increase of any sound. So normal resonance, when a patient talks while you're trying to listen over a lung field with a stethoscope, the sound should be muffled. Normally vocal sounds are sharp and distinct over the bronchi. Over the lung fields, though, the words should become indistinct and muffled. The sound generated in the larynx is transmitted along the tracheobronchial tree and gets muffled in the alveoli. If someone whispers, you shouldn't hear a thing in the stethoscope. Abnormal resonance will make the voice easier to hear through the stethoscope because fluid transmits the sound. So that if you can hear somebody whisper, that is abnormal. Any situation where bronchial breathing is heard, the sounds become loud, sharp, and distinct, and this is called bronchophony. In extreme situations, the whispered words come clearly and distinctly, and this is called whispering ventriloquy. The voice will sound like a twang or a bleating goat. I had my Kentucky accent and said bleating goat, and one of the participants at the training gave me a strange look. No, not a bleeding goat, a bleating goat, like ah, 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 ah. So, and that's referred to as egophony. If auscultating over an area of consolidation like a tumor or an abscess or a pocket of mucus or a pleural effusion. Asymmetrical voice transmission points to disease on one side. So, you know, if you, what that is medical terminology for if you hear it on one side and don't on the other. Okay, they've got disease on one side. Now we're going to talk about phonation. Length of phonation of the vowel sound E. Normal phonation should last at least 12 seconds. Normal syllables per breath is 8 to 10 with an easy breath. So there we get to talking about sentence length. And speech therapists look at this all the time, but also PT and OT should be aware of this in a more general sense. Can they complete a sentence? Or are they taking a breath every few words to have to, you know, do they not have sufficient breath support to even have normal conversation? So if we notice that, make a referral to speech. Their voice intensity and quality. Do they have a smooth voice, or is it raspy and coarse? Does it crackle? Do they lose air before they can get a word out? Is their volume so low that it is unsafe? Can they not call for help? Can people not hear what they're saying? In that event, that is insufficient breath support. They may have something going on with the vocal cords. Weakness, polyps that they need referral for speech or further medical investigation. Can they vary their pitch, intonation? Do they have a monotone voice? Do they have a rise and fall of the voice when speaking, or is it just monotone? It could be a voice problem. It could be depression. We need to look into it. Ventilatory response index. This is a measure for breath control. The person is asked to inhale normally and then count to 15 over what should be about 7.5 seconds. It's the number of breaths that the patient needs to complete the count. That would be his score. And the VRI, the Ventilatory Response Index, has been used as an exercise prescription and intensity monitoring method with cardiac and pulmonary rehab patients, as well as heart and lung transplant recipients. In 1997, some researchers reported that people exercising at a VRI level of 1 or 2, so they can, only needed to take 1 breath or 2 breaths to complete counting to 15 aloud. So people exercising at a VRI level of 1 or 2 were within recommended exercise intensity ranges for safe and beneficial aerobic training levels. There aren't norms for this scale, though. That's the only research I could find on use of the VRI. But you can use it to document an individual's level of breath support, and so use it against themselves, the progress against themselves. Speech language pathology considerations with pulmonary patients. Vocal fry. I have got some vocal fry right now because I have recorded 2 trainings in one back to back. So it's the creaking sound, and it is, if somebody has that, it can be from needing to take a drink of water. It can be from problems with the vocal folds. So if somebody continually has that, make a referral to speech. Now, what am I? We already talked about the norm for phonation is 12 seconds. The SZ ratio isn't being able to vocalize the S sound versus the Z sound, because one is with an open vocal folds and one is with closed, and the ratio should be 1 to 1. They should be able to say s for as long as they say z, and in a shorter a shorter ratio than 1 to 1 may indicate a vocal fold pathology. So that would indicate a referral to speech, and then they can take it from there. If the problem is thought to be other than vocal cord weakness, they will need to refer for medical care. Some exercises that can be done to work on breath control is to have the patient pant like a dog, because that requires contraction of the abdominal muscles and control of the vocal folds. To speak while doing another motor activity, that requires it's a dual cognitive task, and it requires more energy expenditure. The treatment considerations, what I wanted to talk about there, the majority of vocal pathologies under there, I wanted to talk about vocal hygiene. They need to drink water, and that is a major consideration in our facilities, I think, because of the big containers of water and then those huge straws. We're talking about respiratory strength, breath support. I don't know how many of our patients can drink through those big straws. Making sure that our residents can access fluids, access water. Don't scream, and it says don't scream, but what about if they have weakness of their vocal folds? Even talking may be difficult for them and damaging to their vocal cords. Talking for a long time, like I'm doing, and that's what causes me to have vocal fry. Whispering, that is damaging to the vocal cords because it tenses the vocal cords and is not good for them. Hard glottal attacks, and an example of a glottal attack is like James Brown does. Inadequate breath support for talking, eating, or doing your ADLs, just running out of strength because of weak core muscles, diaphragm, abdominals. On the next page is a vocal intensity level chart, and I found this interesting. What intensity of in decibels do you need to hear somebody, and then what is damaging? It gives some just 3 examples. 40 decibels is the sound pressure level that's in a library in the old days, I would say. I don't know how loud it is in a library now. A lot louder than when I was a child. You had to be like it was in a church in the old days. 60 decibels, they give an example of conversation in a restaurant. Again, are we talking about Vincenzo's, or are we talking about what's the kids' restaurant? Chuck E. Cheese. Another example they gave was an air conditioner at 100 feet away. That's pretty loud. 100 decibels is a power lawnmower, a jackhammer, a garbage truck. So we're only talking about 60 decibels difference between a library and damaging sound level. Some comments I have about sound levels. There is a free app that's available on your phone if you wanted to document sound intensity levels. And before you say, Tammy, you are so anal, sometimes I think about that you may want to record those, and I should have looked up again because I keep forgetting what sound intensity is can cause hearing damage. I'll see if I can look this up on this other computer real quick. What sound level you need to for conversation, and what sound levels are damaging. At one of our facilities, I was in with a patient who has dementia, and he also has severe, and severe respiratory problems. And he had his oxygen concentrator, and he had that positive pressure machine, which is insanely loud. And I was thinking about, oh my gosh, not only is this probably damaging to his hearing, but think about the sensory disorientation that it causes when that's going 24 hours a day. The deprivation, the confusion that causes for somebody who already has some dementia, and I just it's just not right. Um, that level of noise, it's the decibels have got to be way off the charts. And I'm going to download that decibel intensity record app, and next time check that, because that's just crazy. But on the other hand, if somebody's vocal intensity is so low that they couldn't, let's say they fell and they can't reach their call bell, and they're calling, nurse, 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 help, help, and they can't be heard in the hallway, that's a safety problem. So they need to be treated either to restore their vocal volume, or to come up with a compensatory or adaptive system so that they can get help in a situation where they're stuck on the toilet, they've fallen at the bedside, they're choking, whatever. They need to be able to get help. Safe for the human ear, let's see. Safe for the human ear. At 91 decibels, your ears can tolerate up to 2 hours of exposure. The human ear can safely withstand sounds around 140 decibels. May be dangerous at 100. So, okay. So, clinical assessment of the voice in medically complex patients. Some voice disorders or conditions typically seen. Hoarseness or harshness could indicate cancer. Some factors that contribute to voice disorders in this population: frequent coughing. Some hypertension medications can cause frequent coughing and throat clearing, which I didn't realize till I did this training. The last thing I wanted to review is that there is a resource in the manual called Clinical Management of Voice Disorders in the Medically Complex Patient. It's a resource for the speech-language pathologist. It goes over clinical situations that the speech-language pathologist may encounter, some problems that you may encounter, clinical situations, and then findings and suggested treatments. So you can just go over those. Hold for a second. I moved my computer into this room and didn't bring that. I'll wait just a minute, and you can look at the U of L poster on the wall. Okay, sorry about that. So prepared. I thought I was, and then I changed my room. Okay. Oh, for Pete's sake, gotta pull that section out. I sure did. There it is. Okay. Okay, the clinical management of voice disorders looks like this in your book. So like for example, general observations, This is a just too general to even talk about. But the next one is phonation evaluation tasks. Tape record a speech sample, determine their maximum phonation time, determine their SZ ratio. If aphonic, tell some jokes to determine whether phonation occurs with laughing. Some of the findings, you may find that they have a hard glottal attack. You may find that they have frequent coughing or throat clearing. You may find that they have inadequate breath support. You may find that they have inadequate hydration. So, and then it gives you some ideas for treatment option. Chewing technique, chant talk technique, whisper phonation method, yawn sigh method, open mouth approach. Okay, so those are some ideas for phonation. Then it goes through intensity. Again, some evaluation tasks for that. Findings, treatment options, pitch as the topic, and then lastly, quality. Some evaluation tasks, some possible findings, being hoarseness, harshness, breathiness, tenseness, wet vocal quality, and then some treatment options. So you might want to pull that out of your manual and put it in a sleeve, a clear sleeve, and just keep it handy if you find that to be helpful. Otherwise, that is the end of this section, and I hope you have found it to be helpful. Thank you for your attention. Have a good day.